Imagine a silent, relentless force, constantly at work within your body, often without a single whisper of its presence.
hmm
It affects millions, yet so many people are completely unaware.
Yeah, it's quite staggering.
This isn't some sci-fi thriller, it's the reality of something as fundamental as your blood pressure.
And left unchecked, this quiet pressure can silently, chip away at your heart, your brain, your kidneys.
Leading to really devastating outcomes like strokes, heart attacks, even kidney failure.
It's serious stuff.
But the good news, the really vital news, is that armed with knowledge, we can confront this silent challenge head on.
Absolutely. Knowledge is power here.
Okay, let's unpack this. Today, we're diving deep into a topic that touches nearly everyone's life, directly or indirectly. High blood pressure or hypertension.
Right.
We've got our hands on the very latest 2025 guidelines from the American Heart Association and a consortium of other leading medical organizations. Our
Our mission is to distill these extensive sources, these really comprehensive documents, into the most crucial nuggets of knowledge.
giving you a shortcut to being truly well-informed about prevention, detection, evaluation, and management of high blood pressure in adults.
And what's fascinating here is how these guidelines synthesize just vast amounts of cutting-edge research into practical, actionable recommendations.
Exactly. We'll explore not just what the numbers mean, but why they matter to your everyday health.
Providing that essential context and helping you understand the real-world implications for your well-being. It's not just theory.
Before we jump in, though, a quick but heartfelt shout-out to London Heartbeat C Academy UK
Oh, yes.
for their invaluable educational support for this deep dive. If you're as passionate about learning as we are, you absolutely have to explore their incredible resources.
They offer over 150 popular courses designed to broaden your horizons. Really impressive range.
And for free, regular updates and amazing discussions, you should subscribe to their social media channels. They're on Facebook, Instagram, and YouTube.
Definitely worth following to stay updated.
And for those who want to take their learning even further, consider their higher-level YouTube membership.
Right, that gives you early access to educational videos and even the chance for personal chats and guidance sessions.
They're doing truly vital work in making knowledge accessible, and we're just so grateful for their support.
Here, here, a big thank you to them.
Okay, so to kick things off, let's think about a real-world scenario. Consider Sarah, a busy professional, maybe late 30s.
Okay.
She felt completely fine, maybe just a bit more stressed than usual, nothing major.
Pretty common these days.
But during a routine checkup, her blood pressure reading was consistently high. And she was genuinely surprised, having no obvious symptoms whatsoever.
That's the tricky part, isn't it? The lack of symptoms.
This initial, unexpected finding became her wake-up call. It led to further testing and, well, a comprehensive lifestyle overhaul.
Sarah's situation perfectly illustrates the profound importance of early detection and accurate measurement, exactly as outlined in these new guidelines.
Right.
Her initial elevated readings, even without symptoms, were a critical alarm bell. They prevented potentially serious complications down the line by prompting her to address it before it became a crisis.
So this really highlights how crucial even a single accurate blood pressure reading can be.
Absolutely. Yeah. It's like having an early warning system. It tells you something needs attention before you even feel a twinge.
Allowing for timely intervention and preventing progression to, more severe stages.
Exactly. It's proactive health management. Quiet pause.
All right, now that we've seen the impact of a single measurement, let's talk about the very foundation of understanding blood pressure.
Let's do it. The basics.
What are we actually talking about when we say blood pressure, and how do the experts categorize it in these new guidelines?
Okay, well, think of your blood vessels like a system of flexible pipes, and your heart is a powerful pump. Blood pressure is essentially the force of your blood pushing against the walls of those arteries as it circulates throughout your body. Simple concept, but vital.
And we always hear about two numbers, right? Systolic and diastolic.
That's right, the systolic pressure, that's the top number. This represents the pressure in your arteries when your heart beats and actively pushes blood out.
Like the surge of water pressure when a pump turns on.
Exactly. And then there's the diastolic pressure, the bottom number. This is the pressure in your arteries when your heart rests between beats, refilling with blood.
Okay, so the residual pressure when the pump pauses briefly.
You got it. And the guidelines lay out very clear categories for these numbers, which are just critical for diagnosis and treatment decisions.
So what are those categories?
First up, normal blood pressure. This is when your systolic pressure is less than 120 millimHg, and importantly, and your diastolic pressure is less than 80 millimilli Hg.
Both numbers have to be in that range. Got it.
Correct. Next, we have elevated blood pressure. This is where your systolic reading is between 120 to 129 millimilli Hg, and your diastolic is still less than 80 millimilli Hg.
So not quite hypertension, but a warning sign.
Precisely. It's a nudge in that direction, a clear signal to pay closer attention, maybe start thinking about lifestyle changes.
Okay. Then what?
Then we move into stage 1 hypertension. This is diagnosed when your systolic pressure is between 130 to 139 millimilli Hg, or, notice the or, now your diastolic is between 80 to 89 millimilli Hg.
So if either number is in that range, it counts as stage 1.
That's right. One high number is enough. This signifies a more significant concern, often warranting medical intervention or at least a serious look at lifestyle.
In the highest category.
That's stage 2 hypertension. This is defined as a systolic pressure of 140 millimilli Hg or higher, or a diastolic pressure of 90 millimilli Hg or higher.
Again, just one number needs to be that high.
Yes. And this stage indicates a greater need for immediate and often more aggressive intervention to lower that pressure.
So what this really means for you, the listener, is that this classification system isn't just about labels.
Not at all. It's a critical first step for understanding your risk and deciding on the most effective prevention or targeted treatment plan.
Understanding these categories empowers both you and your clinicians to identify risk earlier and intervene more effectively.
Steering you away from more serious cardiovascular events down the line. That's the goal.
Okay, quick quiz time for everyone listening. If your blood pressure reading is 125 over 75 millimilli Hg, what category does that fall into according to the 2025 guidelines? Is it A, normal, B, elevated, C, stage 1 hypertension, or D, stage 2 hypertension? We'll give you the answer later on.
Good question. Tests the understanding of those boundaries.
Now, you might think taking blood pressure is straightforward, right? Put on a cuff, pump it up.
If only it were that simple. There's a real art and science to getting an accurate reading.
And this is a key insight, isn't it? Because small details can make a significant difference.
A huge difference.
Yeah.
They can sometimes swing a diagnosis one way or another. The guidelines place enormous emphasis on standardized methods for both diagnosis and ongoing management, and for very good reason.
So what are some of those crucial steps before the measurement even starts?
Well, for instance, you should avoid caffeine, exercise, and smoking for at least 30 minutes beforehand.
Why is that?
Because all those things can temporarily raise your blood pressure, giving a false high reading. Imagine trying to get a calm reading right after running for a bus. It just wouldn't reflect your true resting state.
Makes sense. What else?
It's also vital to use a blood pressure device that has been validated for accuracy. You can't just grab any machine off the shelf.
How do you know if it's validated?
There are resources like validatedp.org where you can actually check if a device you're considering buying, or maybe one your clinic uses, meets those stringent standards.
Good tip. And the physical setup, does that matter?
Absolutely. The correct cuff size is paramount. It needs to fit your arm properly and be placed on a bare arm, not over clothing.
Like a belt analogy. Too loose or too tight gives a bad reading.
Exactly. If it's too loose, you won't get an accurate squeeze. If it's too tight, it artificially constricts and raises the reading. And your arm should be supported at heart level. Letting it dangle can falsely elevate the numbers.
Okay, so preparation is key. What about during the actual measurement?
The patient should be relaxed, sitting calmly in a chair for at least 5 minutes before the reading. Feet flat on the floor, legs uncrossed, back supported.
No crossed legs. Interesting detail.
Yes, even that can slightly affect the reading. The room itself should be comfortable, temperature controlled, and here's a big one.
What's that?
Neither the patient nor the clinician should talk during the rest period or the actual measurement. No checking your phone either.
Really? Even just casual chat?
Yep. Distractions or conversation can subtly raise blood pressure. So next time you're getting your BP checked, remember, quiet and still.
Good advice. And often they take multiple readings, right?
They should. Taking 2 or more measurements, at least a minute apart, and averaging them gives a much more reliable picture than just one single reading.
So the crucial point here is that standardized methods are paramount for diagnosis and management.
Absolutely. They reduce variability and ensure the numbers are truly representative. The guidelines even lean towards using automated oscillometric devices, the digital ones, over the traditional oscillatory method with a stethoscope in the office.
Why is that?
Primarily due to consistency and reduced observer bias. The machine does it the same way every time. This commitment to precision helps clinicians make the most informed decisions for your health.
Okay, another quick quiz. Imagine you're at the doctor's office for a BP check. Which of these actions would not contribute to an accurate reading? A. Resting for 5 minutes before the measurement. B. Chatting with the nurse during the measurement. C. Having your arms supported at heart level. D. Using a cuff that fits your arms snugly. Think about that one.
Tests that attention to detail.
Now, once hypertension is suspected or confirmed, it's not just about the numbers anymore, is it?
No, definitely not. It's about gathering a full picture of your overall health. The guidelines recommend a pretty comprehensive set of laboratory tests and diagnostic procedures.
And why are these tests so important?
They serve multiple crucial purposes. First, they provide a baseline of your overall health. This is vital for guiding management decisions because hypertension rarely exists in a vacuum.
Right, it often interacts with other conditions.
Exactly. Knowing your kidney function, your cholesterol levels, your blood sugar, this directly impacts what kind of medications might be best or what other health issues need simultaneous management.
Okay, so baseline info. What else?
Second, these tests are critical for monitoring for potential adverse effects of therapies. Some BP meds can affect kidney function or electrolytes, for instance.
So checking that the treatment isn't causing other problems.
Precisely. And they also help track changes in your predicted cardiovascular disease risk over time. These aren't just one-time tests. They should be repeated, usually at least annually, to keep an eye on things and adjust your plan if needed.
Makes sense. Any other reason for these tests?
Yes. Additional diagnostic evaluation should always be considered if secondary causes of hypertension are suspected. We'll get into those later, but basically these are underlying conditions causing the high BP.
So the initial tests help screen for those possibilities too.
Correct.
So what are these routine tests the guidelines recommend? Can you give us an idea?
Sure. It's a pretty thorough list designed to get that baseline. Things like a complete blood count, checking your electrolytes, sodium, potassium, calcium, assessing your kidney function with GFR.
GFR being glomerular filtration rate, how well the kidneys filter waste.
Exactly. Also a lipid profile for cholesterol and triglycerides, checking your fasting blood glucose or hemoglobin A1C for diabetes, and even your thyroid-stimulating hormone, or TSH.
Wow, quite comprehensive. Anything else?
Yes, also a urinalysis and specific urine tests to look for protein, which can be an early sign of kidney damage. And finally, a 12-lead electrocardiogram, or ECG, to check your heart's electrical activity and look for any signs of strain from the high pressure.
The core insight here seems to be moving beyond just the symptom of high blood pressure.
Absolutely. This comprehensive panel helps identify potential underlying causes, assess for any existing organ damage, and ultimately guides truly personalized treatment plans. It's about understanding the systemic impact on your entire body.
Okay, time for MCQ number 3. According to the guidelines, which of the following is not typically considered a routine laboratory test for adults diagnosed with hypertension? A. Lipid profile. B. Urinalysis. C. Thyroid-stimulating hormone. D. Vitamin D levels. We'll reveal the answers later. Quiet pause. Okay, we've covered the basics and the importance of accurate in-office measurements and tests. But what happens when those clinic numbers don't tell the whole story?
Yes. This is where out-of-office monitoring comes into play and has become absolutely crucial in modern hypertension management.
The guidelines strongly recommend using these methods, right, for confirming diagnosis and checking medication effectiveness.
Yes. Class 1 recommendations for both confirming the diagnosis and for titration of medication. There are two main types.
What are they?
First, there's ambulatory blood pressure monitoring, or ABPM. This involves wearing a small, portable device, usually for 24 hours.
Right, the one that takes readings automatically throughout the day and night.
Exactly. It gives a continuous picture of your blood pressure patterns as you go about your normal life, sleep, experience different stresses. It's really the gold standard for getting a true picture.
And the second type?
That's home blood pressure monitoring, or HBPM. This is where you, the patient, take your own readings at home using a validated device.
So empowering the patient to be involved.
Very much so. And it's often recommended alongside co-interventions like patient education or telehealth counseling to make it even more effective.
Now, what about all those wearable devices, smartwatches and rings claiming to measure blood pressure? The guidelines have something to say about those, don't they?
They do, and it's quite definitive. They explicitly state there's a definite no benefit for diagnosis or management using current cuffless BP devices.
Wow, no benefit. That's strong.
It really highlights the current limitations of that technology for serious medical decisions. While they might offer interesting data for general wellness tracking, they are not yet accurate or reliable enough for clinical decisions about hypertension. Stick to validated cuff-based devices for now.
Good to know. And you mentioned blood pressure changes throughout the day, especially at night.
Yes, that's fascinating. Our blood pressure naturally dips during sleep. So while an office reading of, say, 220/80 millimille of each G is normal, your average nighttime ADPM reading should ideally be lower, maybe around a 1065 millimille EHG.
And if it doesn't dip?
That lack of nighttime dip or consistently higher readings outside the clinic, captured by ABPM or HBPM, can be a sign of increased cardiovascular risk, even if office readings look okay.
So it reveals hidden patterns.
Precisely. This dynamic snapshot shows why monitoring over a full 24 hours or consistently at home can be so revealing and crucial for accurate diagnosis and personalized treatment.
The core insight here seems to be that out-of-office measurements offer a far more comprehensive picture.
Absolutely. They get around the white coat effect, that anxiety spike at the doctor's office, and avoid relying on just a short snapshot of a clinic visit.
Giving a more accurate diagnosis and allowing for better treatment adjustment.
Exactly. It's about understanding your true blood pressure patterns.
Now let's talk about the why. What actually drives these numbers up? It seems complicated.
It really is. It's a complex interplay of factors, from what you eat to your sleep habits, genetics, even the air you breathe. It's rarely just one single thing.
Which is why understanding all the potential causes is so important for prevention and management.
Right. The guidelines break them down into two main categories: dietary intake factors and non-dietary factors.
Let's start with diet. What are the key dietary culprits?
Well, the classic one is higher sodium intake. Excess sodium makes your body retain water, increasing blood volume, which bumps up the pressure.
The salt connection.
Yep. But it's not just about salt. Lower potassium, calcium, and magnesium intake also play a role. These minerals have beneficial effects on blood vessels, so not getting enough is detrimental.
Often overlooked, those minerals.
They are. Also, lower diet quality in general diets, lacking fruits, vegetables, whole grains, plant proteins, fiber. These foods contain nutrients that promote heart health.
So the overall pattern matters.
Definitely. And finally, alcohol intake. The quantity really matters here. Excessive alcohol consumption is directly linked to higher blood pressure.
Okay, so that covers diet. What about the non-dietary factors?
There's a significant list here, too. Genetic variants play a role. Some people are just predisposed.
Can't change your genes, but good to know if you have a family history.
Exactly. Overweight or obesity is a major contributor. Excess body fat impacts blood volume, heart rate, hormones. It's a big driver.
Linked to lifestyle, often.
Which brings us to lower physical activity or fitness. A sedentary lifestyle contributes to weight gain and directly impacts blood vessel health.
Makes sense. What else?
Sleep disturbances. This is a surprisingly impactful area. Not enough sleep, poor quality sleep, irregular schedules, and especially disordered breathing like sleep apnea. These can significantly disrupt blood pressure regulation.
Sleep is crucial then.
Absolutely. Then there are psychosocial stressors. The mind-body connection is very real. Chronic stress keeps your fight-or-flight system activated, constricting vessels, raising heart rate and pressure.
The stress effect.
And finally, one that's gaining more recognition: air pollution. Exposure to fine particulate matter can cause inflammation and oxidative stress in the cardiovascular system, contributing to higher BP over time.
Wow, even the air we breathe.
Yeah. So the broader implication here is that hypertension isn't usually caused by just one thing.
It's a confluence of lifestyle, environment, genetics.
Exactly. Understanding these causes helps us craft truly holistic prevention and management strategies. It means addressing diet, exercise, stress, sleep, environment. It's all part of the picture, alongside medication when needed.
It emphasizes that managing blood pressure is a multi-pronged effort. Okay, quiz time again. MCQ 4. Which of the following non-dietary factors is explicitly mentioned in the guidelines as a cause of hypertension? A. Excessive screen time. B. Air pollution. C. Chronic dehydration. D. Overuse of pain relievers. What do you think?
An important one to remember from that list.
Now, this is where it gets really interesting, I think. Sometimes blood pressure isn't what it seems in the doctor's office.
Ah, yes, the phenomena of white coat and masked hypertension.
These really highlight why that out-of-office monitoring we talked about is so vital. Can you define them clearly for us?
Sure, white coat hypertension is when your blood pressure is high in the office setting, but it's normal or maybe just mildly elevated outside the office, like when you measure it calmly at home.
The doctor's office anxiety effect?
Pretty much. The stress of the medical setting temporarily spikes the BP. It's a real physiological response.
Okay, and masked hypertension.
This is arguably the more insidious one. Masked hypertension is the opposite. Your blood pressure is high outside the office at home during daily activities, but it appears normal or only slightly elevated when you're actually in the doctor's office.
Why is that more concerning?
Because it's often missed by routine checks. You might think everything's fine based on your clinic visits, but meanwhile, your body is experiencing high pressure most of the time, potentially leading to long-term damage without you even knowing it. It delays diagnosis and treatment.
That sounds quite dangerous. How do we catch these?
The guidelines emphasize that ambulatory blood pressure monitoring, ABPM, that 24-hour device, is the preferred method for definitively excluding both white coat and masked hypertension, especially in people not yet on medication. HBPM can also be useful, particularly for masked hypertension.
And it's important to identify these because
Studies show that individuals with both white coat and masked hypertension are more likely to develop sustained, full-blown hypertension later on compared to those with consistently normal readings.
so they're not benign conditions, they're predictors.
Exactly. Catching these patterns early allows for earlier intervention. Maybe lifestyle changes are enough, or maybe a prompt starting medication sooner, which can prevent progression and reduce long-term risks.
Zooming out, these conditions really underscore the value of looking beyond the clinic walls.
Absolutely. A normal reading in the clinic could be masking a problem, or a high reading could be an anomaly due to anxiety. The guidelines give clear advice on when to use out-of-office monitoring to clarify things.
Like if someone's office BP is borderline high, but not quite needing immediate meds.
Right. If office SBP is, say, 130/159 or DBP is 80/99, but below that 160/100 threshold, using out-of-office monitoring is reasonable to check for white coat hypertension. It helps avoid unnecessary medication.
And it helps if someone on medication still have high office readings.
Yes, it can help sort out if it's a true lack of control or just a white coat effect persisting despite treatment, or maybe even pseudo-resistance.
And what about maxed hypertension? When should that be suspected, even with normal office readings?
Well, it might be reasonable to check with out-of-office monitoring if someone has normal office BP but has strong risk factors, or symptoms that don't quite fit with their normal readings, or evidence of target organ damage. It's about getting the most accurate picture.
Makes sense. Time for MCQ5. Someone has consistently normal blood pressure readings at their doctor's office, but readings taken at home are frequently elevated. What condition might this indicate? A. White coat hypertension. B. Resistant hypertension C. Masked hypertension D. Orthostatic hypotension. One to ponder.
A classic presentation.
Sometimes high blood pressure isn't just, well, primary hypertension. It can be a symptom of something else going on.
That's right. These are known as secondary forms of hypertension. Identifying them is crucial because treating the underlying cause can often resolve or significantly improve the hypertension itself.
Rather than just managing the symptom.
Exactly. And the guidelines emphasize screening for these secondary causes whenever there's clinical suspicion.
So what are those red flags? What raises clinical suspicion?
It's quite a list, reflecting the variety of potential underlying issues. Things like hypertension that's resistant to typical medications or seem to be drug-induced.
Okay.
An abrupt or sudden onset of hypertension, especially if it's severe, developing hypertension at a young age, say under 30.
Unusual for primary hypertension?
Yes. Also, if previously controlled hypertension suddenly gets worse, or if there's disproportionate organ damage for the level of BP, like the kidneys look worse than expected.
What else?
Very severe, rapidly developing hypertension, what used to be called accelerated or malignant hypertension. New onset of diastolic hypertension in older adults, 65 or older.
Interesting.
Low potassium levels not explained by other causes that can point to hormonal issues. Sleep problems like insomnia or excessive daytime sleepiness, possibly suggesting sleep apnea.
Ah, the sleep apnea link again?
Yes. Finding an adrenal nodule on imaging, a history of early onset stroke, or a family history of primary aldosteronism, which is a specific adrenal gland disorder.
Wow, that's a lot of potential triggers.
It is. And what's fascinating is that finding one of these secondary causes can lead to a specific targeted therapy. Like if it's a tumor producing hormones, removing it might cure the hypertension.
A potentially curative approach.
Exactly. That's why the guidelines strongly recommend screening when suspicion is present and referring to a specialist if screening is positive, because these often need very specific tests and treatments.
Is there one cause they particularly highlight?
Yes. They specifically recommend screening for primary aldosteronism in all cases of resistant hypertension, even if potassium levels are normal, because it's a common and very treatable cause of resistance.
Good to know. All right, MCQ number 6. According to the guidelines, which of the following scenarios would raise suspicion for a secondary form of hypertension? A. Gradual increase in blood pressure over many years. B. Onset of hypertension at age 55 with mild obesity. C. Abrupt onset of high blood pressure at age 25. D. A family history of mild hypertension. Which one fits the pattern? Quiet pause. Okay, let's shift gears into management strategies. Before we even talk about pills, these guidelines really hammer home the power of lifestyle, don't they?
They absolutely do. These are Class 1 recommendations, the strongest evidence emphasizing that lifestyle is foundational. This is where you, the listener, have so much direct control.
Let's break down each factor. First, weight management.
For individuals who are overweight or obese, the goal is a weight loss of at least 5% of body weight. Might not sound huge, but the impact is significant.
How significant?
For every 1 kilogram, about 2.2 pounds you lose, your blood pressure can drop by roughly 1 millHg systolic and 1 millHg diastolic on average.
Wow, that's a powerful incentive. Even modest weight loss helps.
Definitely. Next up, diet. Several key points here.
Sodium is the big one, right?
Yes. The recommendation is less than 2.3 grams per day, ideally less than 1.5 grams. That's less than a teaspoon of table salt per day total. You really have to watch processed foods and restaurant meals.
Reading labels becomes crucial.
Absolutely.
Okay.
Then adopting a heart-healthy eating pattern like the DASH dietary approaches to stop hypertension.
What does DAH involve?
It's not super restrictive. It focuses on fruits, vegetables, whole grains, lean protein, low-fat dairy, while limiting saturated fats, cholesterol, and refined sugars. It's rich in those beneficial minerals we mentioned: potassium, calcium, magnesium.
Speaking of potassium.
Moderate dietary intake, 3.55 grams per day is recommended. Think bananas, oranges, avocados, spinach, potatoes. But there's a caution. Monitor potassium levels if you're at risk for high potassium, like with kidney issues or certain meds.
Okay. What about salt substitutes?
Potassium-based ones can be reasonable options to cut sodium, but again, with that same caution about monitoring potassium levels.
Got it. What about alcohol?
Abstinence or strict limits. No more than 1 drink per day for women, no more than 2 for men. And be clear on what a drink is: 5 ounces wine, 12-ounce beer, 1.5-ounce spirits. More than that directly contributes to higher BP.
And exercise?
A structured program including both aerobic activity and or resistance training is recommended. Brisk walking, swimming, cycling, weights consistency, and appropriate intensity are key.
Finally, stress. Who does that fit in?
Stress reduction techniques like meditation and yoga are considered reasonable. Class 2B. They aren't a standalone treatment, but they can definitely help.
How do they directly impact blood pressure?
They help calm the sympathetic nervous system, reducing that fight or flight response, which constricts blood vessels and raises heart rate. So they complement other strategies.
The core insight here seems to be that your plate and daily habits are your most powerful first-line defense.
Absolutely. These aren't just nice to-dos. They're Class 1 recommendations with strong evidence. They can often prevent or significantly reduce the need for medication. It's empowering.
So when do lifestyle changes need the added support of medication? It's not just about hitting a certain number, is it?
No, it's about your overall risk, especially your risk of developing cardiovascular disease like heart attack or stroke. The guidelines use a risk-based approach to personalized treatment decisions.
Can you walk us through that decision flow?
Sure. The first question is your average blood pressure 490 millHg or higher?
Okay.
If yes, then initiate antihypertensive medications immediately. That's a Class 1 recommendation to lower BP and reduce CVD risk, whether it's primary or secondary prevention.
Simple enough if it's that high. What if it's lower than 420/90?
Then the next question is, do you have existing clinical cardiovascular disease like coronary heart disease, stroke history, heart failure?
Okay.
If yes, then initiate meds if your SBP is 130 millHg or higher, or DBP is 80 millHg or higher. Again, Class 1 recommendation focusing on secondary prevention of these high-risk folks.
Makes sense. What if you don't have existing CVD?
Then we ask, do you have diabetes or chronic kidney disease, CKD, or is your estimated 10-year prevent CVD risk 7.5% or higher?
That's the risk score based on various factors.
Exactly. If the answer to any of those is yes, then initiate meds if SBP is 130 mmHg or higher, or DBP is 80 mmHg or higher. Another Class 1 recommendation, this time for primary prevention in these at-risk groups.
Okay, so what's left? People with BP between 13,880 and 13,989, but without CVD, diabetes, CKD, or high risk.
Right. For those individuals, the guidelines recommend initiating medications if SBP is 130 or higher, or DBP is 80 or higher, but only after 3 to 6 months of dedicated lifestyle intervention attempts.
Giving lifestyle changes a real chance to work first.
Exactly. Still a Class 1 recommendation to treat if lifestyle isn't enough, but with that initial trial period.
What's fascinating here is how personalized this is.
It really is. It's not one size fits all. These risk-based thresholds ensure treatment starts when it provides the greatest benefit, particularly for preventing future cardiovascular events. Two people with the same BP might get different advice based on their overall risk profile.
Much more sophisticated. Okay, so once medication is indicated, what are the first-line options for primary hypertension?
The guidelines are very clear on the recommended classes for preventing cardiovascular disease. There are essentially 4 main groups.
Which are?
Thiazide-type diuretics, the water pills, long-acting dihydropyridine calcium channel blockers, CCBs, these relax blood vessels, and then ACE inhibitors, ACI, or angiotensin receptor blockers, ARBs. They work on that key hormone system regulating BP.
So those are the top choices. What about starting with 1 versus 2 drugs?
Good question. For stage 1 hypertension, 130, 139 systolic, or 80, 89 diastolic, initiating a single first-line agent is reasonable. You start with 1, increase the dose if needed, and then add another agent sequentially if control isn't achieved.
A stepped approach.
Right. But for stage 2 hypertension, 40/90 or higher, the recommendation is stronger. Initiate 2 first-line agents from different classes right from the start.
2 drugs immediately. Why?
Because the blood pressure is significantly higher, and it's more likely you'll need 2 drugs for control anyway. Plus, they recommend ideally using a single pill combination.
Putting both meds in 1 pill.
Exactly. This significantly improves adherence, makes it easier for patients to take their medication consistently.
Makes sense. Fewer pills to remember. Now, is there anything you absolutely should not do when combining meds?
Yes, a crucial warning, Class 3, indicating potential harm. You should never combine ACE inhibitors, ARBs, and or renin inhibitors.
Why is that combination so dangerous?
Because they all target the same renin-angiotensin system. Combining them leads to excessive blockade, increasing the risk of serious kidney problems, dangerously high potassium levels, and low blood pressure. More is definitely not better here. It's harmful.
Got it. Avoid that specific combo. The overall insight seems to be maximizing effectiveness while minimizing complexity.
Precisely. And that emphasis on single pill combinations for stage 2 really speaks to the importance of adherence, which, let's face it, is a major challenge in managing any chronic disease. Simplify the regimen, improve the outcome.
Okay, time for MCQ 7. For adults initiating antihypertensive drug therapy, which of the following combinations of medication should typically not be used together? A, thiazide diuretic and a calcium channel blocker. B, ACE inhibitor and an ARB and a calcium channel blocker. D, thiazide diuretic and an ACE inhibitor. Which pair is the no-go?
Tests that critical warning.
Taking medication daily for a chronic condition like hypertension can be really tough, can't it? Remembering every day, maybe multiple times a day, even when you feel fine.
It's a huge challenge.
Yeah.
Adherence is often the Achilles heel of chronic disease management. But the good news is the guidelines offer practical strategies to help ensure people stick to their treatment plan.
What are the most highly recommended strategies? The Class 1 ones.
2 key ones we just touched on. First, using single pill combination therapy whenever possible. 1 pill, fewer doses, easier to remember.
Makes perfect sense.
And second, prescribing medications with once-daily dosing. Simplicity is absolutely key for consistency. Remembering once a day is far easier than 2 or 3 times.
So simplify the regimen as much as possible. What about other helpful interventions, the Class 2A ones?
There are several reasonable strategies here, too. Education and coaching are important. Understanding why the medication is necessary and how it works can be a powerful motivator.
Knowing the why.
Exactly.
Yep.
Medication synchronization, or MedSync, where your pharmacist coordinates all your refills to happen at the same time.
Oh, that sounds convenient. Fewer pharmacy trips.
It really helps. Using reminder aids, simple things like pill boxes, phone alarms, or dedicated medication reminder apps.
Leveraging technology.
Yep. Also, home blood pressure monitoring with feedback. Seeing the direct results of taking your medication, watching those numbers improve, provides powerful positive reinforcement.
Seeing is believing.
And finally, managing anxiety and depression. Mental health significantly impacts adherence. If you're struggling, it's harder to maintain routines and prioritize self-care. Addressing these barriers is crucial.
It really takes a holistic approach, doesn't it?
It does. What's fascinating here is that recognition that adherence isn't just about the drug, but about the patient's entire context, their understanding, their support system, practical barriers, mental health. It's about addressing all of it.
A truly comprehensive view. Okay, MCQ number 8. According to the guidelines, which of these strategies is a Class 1 recommendation to improve antihypertensive medication adherence? A. Regular telehealth counseling. B. Using a single pill combination. C. Managing anxiety and depression. D. Using medication reminder apps. Which one hits that top tier?
Focus on the class ones.
So once you're on a management plan, what's the target? What blood pressure numbers are we actually aiming for?
The guidelines specify goals, and smartly, they vary slightly based on your individual cardiovascular risk. It's personalized.
Okay, how do they vary?
For adults with confirmed hypertension and a 10-year ASCVD risk of 7.5% or higher, remember, that's the calculated risk of heart attack or stroke.
Right, the higher risk group.
For them, the blood pressure goal is quite clear. Get the systolic blood pressure, SBP, to less than 130 millimillar Hg, ideally even less than 120 millimillar Hg, and the diastolic, DVP, to less than 80 millimillar Hg. This is a strong Class 1 recommendation.
So aiming low for the higher risk folks.
Exactly. The benefits of achieving lower targets are more pronounced for them.
What about adults with hypertension but without that high 10-year risk, lower risk individuals?
For them, the general goal is actually the same.
Ah.
SPP less than 130 millimillar Hg, ideally less than 120, and DVP less than 80 millimillar Hg. However, this is a slightly weaker recommendation, Class 2B.
Why the weaker recommendation if the target is the same?
It suggests that while 30/80 is still generally the aim, the intensity of intervention to get there might be balanced more carefully against potential side effects or patient preferences in this lower risk group. The evidence base for pushing to the absolute lowest end might be slightly less robust for them compared to the high-risk group.
So the core insight is that the ideal BP isn't one number fits all.
Precisely. It's tailored to your overall cardiovascular risk profile. The ultimate goal isn't just treating a number, but reducing your risk of future events. Generally, lower is better when tolerated, but the approach is personalized. Quiet pause.
All right, let's dive into some specialized management scenarios. Hypertension often doesn't exist in isolation, right? It interacts with other common health conditions. Let's start with diabetes.
Yes, this is a huge area. The guidelines highlight a critical point. Over 80% of adults with type 2 diabetes also have hypertension.
Wow, 80%.
It's incredibly high comorbidity. This means managing one often impacts the other, and achieving intensive blood pressure goals in this population is strongly linked to better cardiovascular outcomes. It's just as important as blood sugar control.
So what's the BP goal for people with diabetes?
The recommendation is clear. Use antihypertensive medication if the SBP is over 130 millimillar Hg or the DBP is over 80 millimillar Hg. That's a Class 1 recommendation treat to get below 130/80.
And the initial medication choices.
All the first-line agents we discussed, thiazides, CCBs, ACE inhibitors, ARBs, are considered effective. The choice might depend on other individual factors.
But are there special considerations if someone with diabetes also has chronic kidney disease, CKD?
Yes, definitely. If their kidney function eGFR is below 60, or if they have significant protein in their urine albuminuria, then ACE inhibitors or ARBs are specifically recommended.
Why those specific?
Because they have a proven kidney protective effect in people with diabetes, slowing the progression of kidney disease. What's even more striking is that even with mild albuminuria, ACEI or ARBs can still play a crucial role in delaying that progression.
So they offer organ protection beyond just lowering BP.
Exactly. It's a dual benefit, crucial in this population, given the high risk of kidney complications from diabetes. This coordinated strategy is essential.
Okay, moving on. Given the rising rates of obesity, how do the guidelines suggest managing hypertension in this group?
It's a very common combination, and the guidelines suggest specific adjunct therapies that tackle both weight and blood pressure.
Like what?
For adults with hypertension and a BMI of 27 or higher, overweight or obese, certain medications used for weight management, specifically incretin mimetics like GLP-1 receptor agonists, may also be effective as an adjunct to lower blood pressure.
So meds that help with weight might also help BP.
Correct. And for those with more severe obesity, say a BMI of 35 or greater, bariatric surgery, combined with behavioral interventions and standard antihypertensive therapy, may also be effective at lowering blood pressure significantly.
Surgical intervention as an option in severe cases.
Yes. This raises the important question. Why is treating obesity so critical for hypertension? It's about tackling a root cause. Obesity drives hypertension through inflammation, insulin resistance, nervous system activation.
So these interventions offer a dual benefit by addressing those underlying pathways.
Precisely. It's a strategic approach for these interconnected conditions.
Now, high blood pressure is a leading cause of heart failure. What's the preventative strategy there?
It's refreshingly simple, but incredibly powerful. For adults with hypertension, treat the systolic blood pressure to less than 130 mmHg, or the diastolic to less than 80 mmHg to prevent the progression to heart failure.
So achieving those standard BP goals is directly protective for the heart.
Absolutely. You're reducing the workload on the heart. High pressure makes the heart work harder, eventually leading to muscle stiffening or weakening. Controlling the pressure prevents that long-term strain.
Clear and direct. What about managing hypertension with chronic kidney disease, CKD? We touched on it with diabetes, but more generally.
Yes, there's a very close link. Uncontrolled hypertension damages kidneys, and damaged kidneys make BP harder to control. It's a vicious cycle.
So specific goals here too.
Yes. If someone has hypertension and CKD, defined as eGFR 60 or significant albuminuria, the SBP goal is less than 130 mmHg. This specific target is recommended primarily to decrease all-cause mortality in this high-risk group.
And medication choice.
Similar to the diabetes CKD overlap, RAAS inhibitors, meaning either an ACE inhibitor or an ARB, but again, not both together, are strongly recommended.
Why? Same reason.
Yes, they decrease cardiovascular risk, and critically, they delay the progression of kidney disease itself by protecting the kidney's filtering units. It's that crucial dual benefit again.
Okay, let's shift to a very acute and serious scenario. Intracerebral hemorrhage, ICH, or bleeding in the brain. How is BP managed then?
This is where management becomes incredibly precise and urgent. Minutes matter.
What do the guidelines say?
For acute spontaneous ICH, where the initial SBP is high, between 150 and 220 mmHg, the recommendation is to immediately lower the SBP aggressively, aiming for a target range of 130 to just under 140 mmHg, and maintain that for at least 7 days. However, if the SBP drops below 130, the BP lowering meds should be stopped or reduced.
A very tight window. Why that specific range?
That specific control lowering has been linked to improved functional outcomes for patients after the bleed.
What if the initial SBP is even higher, like over 220?
Then the approach is slightly different. A rapid reduction by about 25% in the first hour, then a more gradual lowering towards 160, 100, 110 over the next 6 hours, and towards normal over the following day or two.
So speed matters, but also control.
Absolutely. A key emphasis is on smooth, stable control, avoiding sharp peaks and large swings in pressure, which can be dangerous in this setting.
Is there a pressure that's too low?
Yes, a critical warning class 3, harm. The SBP should not be lowered below 130 mmHg in acute ICH cases. Doing so has been shown to increase adverse events, likely by reducing blood flow to vulnerable brain tissue.
It really highlights the delicate balance in acute care, doesn't it?
It really does. High pressure contributes to the bleeding, but dropping it too much or too fast can also be detrimental. It's a very tightly controlled therapeutic window requiring intensive monitoring.
What happens when blood pressure remains stubbornly high despite best efforts? Let's talk about the plan for uncontrolled hypertension.
Yeah, this requires a comprehensive approach. It's often more than just tweaking one medication. The guidelines emphasize several key strategies.
Like what?
First, a team-based care approach is highly recommended. Physicians, nurses, pharmacists, dietitians working together.
A multidisciplinary effort.
Exactly. And crucially, an evidence-based care plan that uses home blood pressure monitoring, HPPM, and team-based care, and specifically addresses adverse social determinants of health, SDOH.
Recognizing those broader societal factors.
Yes, this is key. Things like access to healthy food, safe housing, transportation, socioeconomic status, these directly impact health and must be part of the plan. It's about meeting patients where they are.
What else is in this integrated model?
Accurate BP measurement, prompt treatment adjustments based on readings, especially HPPM, active patient engagement, and ongoing review. It's a continuous feedback loop.
And technology plays a role.
Yes, health information technology is beneficial. Electronic health records, EHR, and patient registries help screen and identify those needing more care. Telehealth interventions are also useful for reducing BP and improving control, especially for access.
And follow-up.
For those starting new or intensified therapy for uncontrolled HTN, monthly follow-up evaluations are recommended to check adherence and response until control is achieved. Consistent, relatively frequent follow-up is key.
The big picture seems to be a holistic system of support.
Definitely. Moving beyond just prescribing pills to a system that supports long-term control by addressing clinical, behavioral, technological, and social factors.
Now, a critical area, hypertension in pregnancy, including preeclampsia. This needs special attention.
Absolutely. The health of both the birthing parent and the baby are at stake, so the guidelines are very specific.
What about for those planning pregnancy or who become pregnant with existing hypertension?
Several key points. Counseling on low-dose aspirin, 81 milligrade, is recommended to reduce the risk of developing preeclampsia.
A simple preventative measure.
Yes. And, crucially, certain medications must be avoided due to fetal harm. Class 3, harm. This includes atenolol, ACE inhibitors, ARBs, direct renin inhibitors, nitroprusside, and MRAs.
A significant list to avoid. What are the preferred medications?
Generally, labetalol and extended-release nifedipine are preferred choices during pregnancy due to their safety profiles.
Okay. What about managing high BP during pregnancy, especially severe cases?
If SBP hits 160 mmHg or higher, or DBP hits 110 mmHg or higher, confirmed within 15 minutes, it needs to be lowered promptly within 30-60 minutes to below those thresholds to prevent acute events like stroke or eclampsia. It's an emergency.
Urgent intervention needed. And for chronic hypertension during pregnancy.
The goal is to achieve a BP less than 440/90 mmHg to prevent maternal and perinatal complications.
And how is preeclampsia diagnosed? It's more than just high BP, right?
Correct. The diagnostic criteria involve new onset high blood pressure after 20 weeks gestation, either sustained readings equals 4790 or a single severe reading equals 60110, plus signs of organ dysfunction,
Such as?
such as significant protein in the urine, proteinuria, low platelet count, impaired kidney or liver function, fluid in the lungs, pulmonary edema, or new onset severe headache unresponsive to medication, or visual symptoms. Any one of those accompanying the high BP can confirm preeclampsia.
It really underscores the complexity and risks here, balancing two lives, specific med choices, urgent interventions.
Precisely. The criteria for preeclampsia are critical for timely diagnosis and management to improve outcomes for both mother and baby.
Let's tackle resistant hypertension, those cases where the BP just won't come down despite optimal treatment. How is that defined?
Good question. Resistant hypertension is defined in two ways. Either your office BP is 130/80 mmHg or higher, even though you're on 3 or more antihypertensives from different classes, including an ACE, INA, all plus CCB plus thiazide diuretic. Or your office BP is controlled below 130/80, but it requires 4 or more different antihypertensive meds to get there.
So either uncontrolled on 3 meds or controlled only on 4 or more.
Exactly. And when this is suspected, a thorough workup is essential, a class 1 recommendation.
What does that involve?
First, exclude pseudo-resistance. Is it really resistant, or is it due to inaccurate measurements like white coat effect, or very commonly, poor medication adherence? ABPM and careful adherence checks are crucial.
Rule out the simple stuff first.
Right. Second, review and remove interfering substances. Other meds, even OTCs or supplements, can raise BP. Third, screen for those secondary causes we discussed earlier, primary aldosteronism, sleep apnea, kidney disease, etc.
Got it. Once those are ruled out, what are the treatment steps for true resistant hypertension?
The key next step, a class 1 recommendation, is to add a mineralocorticoid receptor antagonist, MRA, like spironolactone or eplerenone, assuming kidney function is adequate. eGFR equals 45.
Why MRAs specifically?
They block the effects of aldosterone, a hormone often implicated in resistant hypertension. It's a different mechanism than the first-line drugs.
What if MRAs can't be used or aren't tolerated?
Then adding an alternative second-line agent is reasonable, class 2A. Options include amiloride, another diuretic, beta blockers, alpha blockers, or sometimes others like central sympatholytics or vasodilators in specialized cases.
This raises the question again. Why is ruling out pseudoresistance and secondary causes so vital before adding these extra drugs?
Because if the real issue is non-adherence, or an underlying condition like sleep apnea, simply piling on more BP meds might not work well and just increases side effects. Addressing the root cause or the adherence barrier is often far more effective.
Makes total sense. Okay, MCQ time. Question 9. Which of the following describes resistant hypertension? A. Blood pressure is normal in the office but high at home. B. Blood pressure remains high despite taking 3 or more antihypertensive medications of different classes, including a diuretic. C. Blood pressure is only high during stressful situations. D. Blood pressure is difficult to measure accurately. Which one fits the definition?
Should be clear now.
For those truly resistant cases, new frontiers are emerging beyond just medication adjustments. Tell us about renal denervation, RDN.
Right, RGN is a procedural treatment. It involves using energy, like radiofrequency or ultrasound, to ablate or disrupt the sympathetic nerves around the arteries leading to the kidneys. These nerves play a role in BP regulation.
A procedure to lower blood pressure.
Yes, but the guidelines position it carefully.
Hmm.
They say RDN therapy may be a reasonable adjunct treatment, meaning in addition to, not instead of meds and lifestyle changes for resistant hypertension. It's a Class 2B recommendation.
Who is it for specifically?
It's considered for a very specific group, those with resistant hypertension, office SBP 140-180, PBP equals 90, with adequate kidney function, eGFR 40, despite being on optimal medical therapy and/or having limiting side effects for meds.
So, not a first-line thing at all.
Definitely not.
Yeah.
And the guidelines are very clear. Any patient considered for RDN must be evaluated by a specialized, multidisciplinary team, Class 1 recommendation, and the benefits and risks must be discussed thoroughly as part of a shared decision-making process.
So, careful selection and informed consent are paramount.
Absolutely.
Yeah.
What's fascinating is the emergence of these procedural options, but it's crucial to see them as adjuncts for specific difficult cases requiring expert evaluation. It shows the field is evolving beyond just pills for the toughest scenarios.
Now, on the flip side of high blood pressure, sometimes managing it too aggressively can lead to orthostatic hypotension, OH.
Yes, that drop in blood pressure upon standing that causes dizziness or fainting, it's a common concern, especially in older adults or those on multiple meds.
How do the guidelines balance aggressive BP control with this risk?
Interestingly, they first recommend that improved overall BP control actually reduces the risk for OH. Better regulation helps the body adjust.
Okay. But what if someone develops RH while on treatment?
It depends if it's symptomatic. For adults receiving intensive BP lowering, aiming for SBP 130, who have asymptomatic OH, the drop happens, but they feel fine. Continuing treatment towards that 130 goal is considered reasonable.
Why?
Because the overall cardiovascular and mortality benefits of achieving that lower BP often outweigh the risk posed by asymptomatic OH in those individuals.
But what if the OH is symptomatic, causing dizziness, etc.?
For adults initiating treatment or adding meds with the goal of SBP 130, assessment for symptomatic OH is reasonable. This helps detect other conditions that might be contributing, or allows for medication adjustments to prevent falls and related problems. It's about safety and comfort.
So it's a nuanced approach again, balancing benefits and risks, especially based on symptoms.
Exactly. Careful monitoring and personalization are key, especially in vulnerable populations.
Let's talk about the most acute situations, severe hypertension and hypertensive emergencies, when BP is dangerously high.
Right. The threshold here is generally SBP 180 mHg or DDP 120 mmHg. But the crucial distinction is whether there's acute target organ damage.
What does that mean?
Is the high pressure actively damaging the brain, like stroke, encephalopathy, the heart, like heart attack, heart failure, aortic dissection, the kidneys, acute failure, or causing severe bleeding?
Okay, so if there is acute target organ damage,
That's a hypertensive emergency. It requires immediate admission to an ICU, Class 1. Specific, rapid SPP reduction targets apply, like getting below 140 mmHg within the first hour, or even 120 in aortic dissection, or reducing by 25%, then gradually stabilizing. Aggressive but controlled lowering is vital.
and if there's no acute target organ damage, even with those very high numbers.
That's classified as severe hypertension, sometimes called hypertensive urgency. The approach is very different.
How so?
If identified in the ED, inpatient versus outpatient treatment depends on other factors, not just the BP number. If identified in an outpatient setting, there's no need to refer to the ED just for the number.
So what should be done in the outpatient setting?
The focus is on reinstituting, intensifying, or modifying their existing medical therapy in the outpatient setting. And crucially, Class 3, harm. Avoid giving IV medications or aggressively intensifying oral meds acutely in the outpatient setting for these non-emergency cases.
Why avoid rapid lowering if there's no emergency?
Because dropping the pressure too quickly when the body has chronically adapted to high levels can cause its own problems, like reduced blood flow to vital organs. Instead, close follow-up, usually within 4 weeks, is recommended.
The key distinction is that organ damage.
Absolutely. It dictates the urgency, the setting, and the intensity of treatment. It's about preventing catastrophe in emergencies, but also avoiding harmful overtreatment in non-emergencies.
Okay, final quiz question. MCQ 10. A patient presents to the emergency department with a blood pressure of 2,120 mmHg. What is the most critical question to determine if this is a hypertensive emergency? A, has the patient taken their medications today? B, are there any signs of acute target organ damage? C, What was the patient's blood pressure last month? D, is the patient experiencing any headache or dizziness? Which question gets to the heart of the matter?
The defining question.
Finally, a very practical consideration. Managing hypertension in patients scheduled for surgical procedures.
Yes, perioperative BP management is critical for safety, the general recommendation.
Continue most antihypertensive medications throughout the perioperative period. Stopping them abruptly can be riskier.
But there are specific nuances for certain drug classes.
Like beta blockers.
Yes, for chronic beta blockers, BB, it's class 1 to continue them. Abrupt discontinuation is not recommended, class 3, harm, due to risks of rebound hypertension or heart issues. Also, BBs should not be started on the day of surgery in patients not already taking them, class 3, harm, unless there's a clear acute need.
Okay, continue chronic BBs, don't stop abruptly, don't start acutely. What about others?
Clonidine, another BP med, should also not be discontinued abruptly, class 3, harm, due to rebound risk. For ACE inhibitors or ARBs, the guidelines say preoperative discontinuation may reduce the risk of perioperative hypotension, low BP during after surgery. This is class 2B reasonable to consider, often discussed with the anesthesia team.
So maybe hold ACARBs, maybe not.
It's a judgment call based on the patient and the surgery. Lastly, if a patient's SBP is very high, say 180 or DBP 110, it's reasonable to consider delaying elective surgery to minimize risks.
The overall picture is balancing the risks of high BP versus low BP during the stress of surgery.
Exactly. Avoiding dangerous highs that could cause bleeding, but also avoiding sudden drops that could compromise organ blood flow. These guidelines provide specific advice for navigating that balance.
Let's revisit David, perhaps. Think of David, who had well-controlled hypertension but needed urgent surgery.
Okay.
His doctors faced the challenge of managing his BP around the procedure, particularly concerning his ACE inhibitor. They had to decide whether to continue it or pause it, carefully following the guidelines.
David's case perfectly illustrates these nuanced decisions in perioperative hypertension management. It highlights the importance of specific guidance on meds like ACE inhibitors and beta blockers, ensuring patient safety during that vulnerable time around surgery.
It really shows how specialized knowledge from these guidelines provides clear recommendations for complex situations like surgery, ensuring continuity of care and minimizing risks.
Absolutely. Practical application of evidence. Quiet pause.
We've covered an immense amount of ground, and these guidelines are incredibly detailed. But science never stands still, right?
That's right. Even with comprehensive guidelines like these, there are always areas where the experts acknowledge more research is needed. They identify evidence gaps and point towards future directions.
What are some of those areas?
Well, there's a need for more research on the best screening and implementation strategies for BT control. How can we do better at finding and treating hypertension effectively in the population?
Okay.
More studies are needed on BP targets and long-term benefits, specifically in younger adults. The data isn't as robust for them. Also, more research on patients with white coat hypertension and their long-term risk. How often do they progress? What helps prevent it?
Understanding that condition better.
Yes. Optimal management of pregnant patients remains an area for ongoing research due to the unique physiology and risks involved. Understanding the genetic and epigenetic risk factors for hypertension is another big frontier. Could this lead to more personalized prevention?
The genetic link.
Absolutely. And critically, understanding the complex intersection of BP, race, ethnicity, and social determinants of health. How do systemic inequities drive disparities in hypertension?
A really important societal question.
Hugely important. And finally, identifying alternative, accurate methods to measure BP is an ongoing goal. Think more reliable wearables or cuffless technology in the future.
So even with these robust guidelines, the question remains, where do we go next?
Exactly. And what's fascinating is that the guidelines themselves highlight these evolving areas, paving the way for future advancements. It shows the scientific process in action, always questioning, always seeking to improve our understanding and treatment. Quiet pause.
All right, let's try to summarize the big takeaways from this deep dive into the 2025 hypertension guidelines. What stands out most?
Well, first, hypertension is often a silent threat. No symptoms doesn't mean no problem. That makes regular, accurate measurement absolutely essential. You can't feel it, so you have to measure it.
Right. Second takeaway.
Management is definitely multifaceted. It's not just about medication. Those lifestyle choices, diet, exercise, stress management, weight control, play a huge foundational role. They're powerful tools.
Absolutely. Third point.
Not all high blood pressure is the same. Recognizing nuances like white coat or masked hypertension or identifying potential secondary causes can drastically change the management approach and ensure you get the right personalized treatment.
Good point. And finally,
These 2025 guidelines strongly emphasize personalized care. That means using risk assessment tools, setting specific treatment goals based on comorbidities like diabetes or kidney disease, and using a team-based approach to ensure the most effective and safest outcomes for each individual.
excellent summary. Okay, time to reveal the answers to all our quiz questions.
Let's see how everyone did.
MCQ 1, BP 12575. Category, the answer is B, elevated. SBP is 120, 129, and DBB is less than 80.
Right in that elevated zone.
MCQ 2, what would not contribute to an accurate reading? The answer is B, chatting with the nurse. Guidelines say no talking during rest or measurement.
Keep quiet for accuracy.
MCQ 3, which is not a typical routine lab test for hypertension. The answer is D, vitamin D levels. While important for health, it's not listed as routine for initial HTN workup here.
The others, lipids, urinalysis, TSH, are standard.
MCQ 4, which non-dietary factor is mentioned as a cause? The answer is B, air pollution, specifically listed in the guidelines.
An important environmental factor.
MCQ 5, normal office BP, high home BP. The answer is C, masked hypertension, high outside the clinic, normal inside.
The hidden kind.
MCQ 6, scenario suspicious for secondary hypertension. The answer is C, abrupt onset of high blood pressure at age 25. Young onset is a key red flag.
Warrants further investigation.
MCQ 7, which medication combo should not be used? The answer is B, ACE inhibitor and an ARB, class 3 warning potential harm.
Never combine those from the same pathway blockade.
MCQ 8, class 1 recommendation for adherence. The answer is B, using a single pill combination simplifies the regimen effectively.
Along with once daily dosing.
MCQ 9, which describes resistant hypertension. The answer is B, blood pressure remains high despite taking 3 or more antihypertensive medications, including a diuretic. That's the core definition.
Or controlled only on 4 or more meds.
And finally, MCQ 10, critical question for 2120 BP in the ED. The answer is B, are there any signs of acute target organ damage? That's the key differentiator for hypertensive emergency.
Determines the urgency and treatment approach. Hope those explanations helped.
So after all this detail, what does it all mean for you, our listener? Perhaps the most powerful takeaway is this. Knowledge isn't just power, it's preventative medicine.
Absolutely. Understanding these guidelines means you can engage more effectively with your healthcare providers. You can ask better questions, advocate for the right tests and monitoring.
And make truly informed lifestyle choices. You become an active, empowered participant in your own health journey.
So the provocative thought to leave you with is this. How will this deeper understanding of hypertension influence your next conversation with your doctor, or even your choices today or tomorrow?
Because ultimately, managing blood pressure is an ongoing journey, not a one-time fix. And you are the most important member of your own health team.